joining us tonight, wherever you're tuning in from, whether it's Hawaii, London, Portugal, or down the street from Mark in Detroit. We do appreciate your time. We promise to be entertaining and also give you some info tonight.
We promise to try to be entertaining. We might not succeed.
That's true. We will both bring our goofy here, and hopefully you'll be entertained. So a couple of CE things to get it out of the way. This is an ADD PACE CE event. So that means if you hang out with us for the vast majority of this 1 hour together, you will get one CE. If and only if you complete the survey at the end, we will send a link in the chat. Like always, we will also send you an email this evening. You'll get that within an hour of the webinar concluding. If you fill out the questionnaire, it should take you roughly 32.8 seconds. It's a couple of check boxes. You can do it. Get your CE. And outside of that, we want to welcome Dr. Mark Murphy, the man who needs no introduction.
Oh my God.
Mark, I have to say, before we hop into tonight's content, please give us your, for those that maybe have not heard of your infamousness, if that's even a word. Give us your backstory and please tell us about prosomnus. I know that's not going to come up a whole lot in our topic tonight, but go ahead, man. Lead us there.
Well, thank you, Michael. So for me, it's easy. I graduated from dental school in 1981. 1985, ended up down at this place called the Pankey Institute. Well, I'm teaching down there, and wow, I think back to it's probably 1990, so 32 years ago. I'm teaching with a guy named Keith Thornton. That name might ring a bell for some of you. And so I'm teaching with Keith Thornton, and we're teaching a TMD class, and we're making splints, and we're adjusting bites, and we're having a ball. And Keith's talking to me about, and I knew a little bit about chronic pain syndrome and fibromyalgia treatments. And he said, "You really got to start getting into sleep apnea." So he nudged me to make my first tap appliances back in that day. I mean, holy crap, that was, like I say, 32 years ago. So 30 plus years ago, I'm making tap appliances. They look like an upper impression tray with a handle sticking down out of the palate, and the lower tray was flat. So this thing would hit on this flat portion. You'd have to advance the mandible so this could drop down. There was no titration. There was no pre and post test. There was no conference with physicians or anything like that. We were just breaking every rule we could unintentionally. We didn't know any better. People got better. We probably jacked up some jaws and screwed up some bites, but people were sleeping better and snoring less and staying with their spouses. We might have saved a few marriages, etc. So I dabbled around in sleep along with my TMD for a long time, and then the rules kind of got a little trickier about it, talking about what we should and shouldn't be doing and how we should have tests and work with physicians and need a prescription. So I got a little scared. I backed away from all that. So I was still teaching at Pankey. I still teach at Pankey. I teach the sleep course with Remmers and Karstensen and all the other folks down there. And so I backed away from it for a little bit. And then back in, hilarious, back in 2012, I get diagnosed myself with having obstructive sleep apnea. So I order up a device for myself. I might not have conferred with a physician, or I may have, I don't know. I don't recall. I'm trying to block it out. And off we go. I'm self-treating myself, and I get better. And 2013, I'm doing some lecturing and teaching for Microdental, and they decide to launch a product called the Micro2. It was a very weird device because it was iterative advancements. It was these different arches. You trade out an arch to advance a mandible instead of turning a screw or screwing a tube or putting on a strap or something like that. Totally weird, but it was so cool. And it took off. And so when Microdental sold to Modern Dental in China, the sleep product, Micro2, became a company called Prosomnus. And that was in 2016. So 2013, we started developing a device. In 2014, we got FDA approval. In 2016, we became a real company. So we've had about a 5-year run. And while I'm sitting here with you today, this year we're actually larger than Somnomed in terms of sales in the US and Canada, North America. So we've gone from 0 to 60 miles an hour on a ramp that looks like a hockey stick in terms of growth and development, because the devices they make are very different. Nobody makes devices the way we do, period. So I'm having a blast doing that. I practice 1 day a week doing dental sleep medicine. Prosomnus likes that I do that, thank goodness. So I get to see patients a little bit. So I get to do things like you all do and see patients and order up HSTs and get trained. And you've got some great training people there and everything like that. So I get to do all that kind of stuff. So that's kind of fun. And ProSomnus is kind of a unique beast. We've got 5 different devices. Thank you for the intro for that. So although we've got an iterative advancement called the IA and a smaller one called the IA Select, and we've got a dorsal looking device called a CA or continuous advancement LP or precision hertz, the PH. They're all cool devices. Got to have a PDAC Medicare device. The Evo is the cat's pajamas today. It's now the #1 seller. It launched April 1st officially, and it's now the #1 seller in North America, the #1 product ordered in North America. It's like the IA Select, but it's got a little bit of flexibility to it. It doesn't stain, looks brand new after 4 or 5 years, is incredibly precise and accurate. It's the smallest device on the market. It's got the most tongue space, things like that. So ProSomnus, because tonight's not about ProSomnus. Tonight's about helping dentists do more sleep. So I don't want to get off on too much of a tangent. But Michael, ProSomnus has focused their company from the first day, and I'm fortunate to be with them, saying, how do we help sleep dentists be more successful? And one of the things they found out early on was, we're not going to be successful unless we help physicians learn to trust oral appliance therapy. Until dentists can earn the hearts and the minds of sleep physicians who control $4.5 billion worth of prescriptions every year. And in oral appliance therapy, we get about 120 million. Now just think about that. We're about 5% of the market. So at that low level, until we can convince them to shift 10% or 15% of their prescribing patterns towards us, where we would triple or quadruple the market overnight, we can talk about anything we want, and it really doesn't matter. So we have to make devices that are better, that are more precise, that are more accurate, that are smaller, that have fewer side effects, et cetera, and that physicians can come to trust. So ProSomnus has dedicated itself to doing that kind of thing. And so that's why they're exploding and growing really, really well. And that's just super fun to be a part of.
Awesome. Well, I have to backpedal a quick step. I forgot to let everybody know that if you have questions, which I'm sure you do tonight, please hit us in the Q&A. Let's keep the chat for answers to any of Mark's questions or text.
And email me. Feel free to email me. There's my email address there. You can always email me. I get back to you in a day or two. We'll get on a call, whatever you need to do. If there's questions about what we talk about tonight, Michael and I are both free to get on a call and do any of that kind of stuff you need to do.
Yep. Awesome. So you kind of parlayed into that really well. Why don't you hit us with what on earth doctors do to get their patients to yes when we in a dental practice find it so hard oftentimes. Mm-hmm. I know that's where we're going.
Yeah.
But, why don't you hit us strong right out of the gate, man?
So it's funny because I've spent a lot of my career teaching dentists how to be more successful at case acceptance, treatment planning and case acceptance. And the rules are kind of the same for dental sleep medicine, but there's a couple of differences, and the differences are big because in dentistry, we don't have anything called insurance. We call it insurance, but it's not insurance. If you look up the word insurance in a dictionary, it says when a third party takes the risk for a catastrophic loss, and there's no catastrophe in $1,200 or $1,500. If you totaled your car and you went down to see the gecko because you had Geico insurance, and you said, "Here you go, you've totaled your car. Here's a check for $1,200 or $1,500." You'd choke that little bugger till his eyes popped out, And if you said, "Flo, help me out here. This insurance sucks," and she said, "I can save you $300 or $400 in 15 minutes," she'd say, whoa, what does your insurance cover? And if Flo said it covers oil changes, lube jobs, and filters twice a year, new wiper blades every 3, new tires every 5, you'd say, that doesn't sound like insurance. It sounds like a maintenance plan. So don't get me wrong, we call it insurance, but it's not. When your medical insurance starts at $1,500, $2,000, $3,000, $5,000, $8,000, the deductibles, but they go on forever to cover catastrophic loss. That's real insurance against a catastrophe. So medicine's different. The financial management is different. The cost basis is different. It's not discretionary. Listen to that. Letter of medical necessity. We all get those. Letter of medical necessity, not letter of if you want to do this. Letter of medical necessity. That's different. So when we look at medicine and we say, what did we learn about case acceptance? All cool, let's talk about that. But how do we apply this medical, filter on top of it? Then I would say there's 4 things we've got to really think about tonight. We're going to talk about, in the next 45, 50 minutes. How do we understand the patient's journey? How do we really understand how a patient thinks? how a patient makes decisions, not just for dental care, but for medical care, because medicine is huge. Dentistry is about 5 to 6% of the healthcare dollar. So medicine has spent a tremendous amount of time, effort, energy, and money researching how patients make their decisions. And so they've set up systems that support patients moving forward through the healthcare system. They haven't built barriers and obstacles and things for them to jump over to get work done. So we have to understand the patient's journey through all that. And then we have to be very intentional when we screen our patients, when we talk to our patients about sleep. It's not just like, well, did you see the poster out in the waiting room? What did you think? Do you have any questions? No, we have to be very intentional. We have to guide the conversation. We have to ask questions. We have to use things like the Epworth Sleepiness Scale and the Stop Bang to take the patient on a journey to want to know more, to go down to the next question, to create curiosity in their minds, to help them figure things out with us as we go along. So they're sort of co-discovering and they're going, aha, oh, that sounds like me. Yes, I want them to become curious. And then we have to answer these 3 critical questions that every single medical patient has in their mind. And we'll talk about those later, I promise. And then we have to have the right systems in place, because if I'm going to be all in with insurance, my model looks different than if I'm fee for service. If I'm going to use an HST company like Awaken to Sleep, then I've got a different business model than if I'm sending all my patients to my local physician. And if so there's different components to the different kinds of systems. Well, if I'm just screening my patients and seeing my patients, and I'm not seeing patients from other physicians or other dentists or something like that from a referral basis, then my screening, testing, treating, and billing kind of protocol is going to look and feel a little bit different. So there's different things we have to really think about and make decisions about as we're setting up these systems, so we build the right systems to do the right things for our practice. And if we do these 4 things, honestly, Michael, even kind of half-assed, we will score big time. But if we don't do anything at all, we just jump all around doing all kinds of different things and trying them, we will suck at all of them. That's the bottom line.
Well, I think you said something key there. It doesn't quite matter as much what pieces you have.
Right.
You have to have a system. It's not just insurance or fee for service or HSTs or not. There isn't like one magic bullet. It's a clip full of lead ones, pardon the example. And it's just consistency, but that system is really going to be the moments that you have for impact with the patients, right? I mean, that's what we were talking about tonight.
Yeah, I'm hearing you say there's no wrong answer, but pick one for God's sakes and build a system to get to it.
Bingo.
Yeah. Because leadership and management are very different. Dentists, we are very, very good at managing things, organizing things, measuring things, checking things off a list. We're very good at that. But we're not always good at figuring out what the right thing to do is. And so it's important that we understand the difference between management and leadership. Management is making sure we do things right. But leadership is making sure that we're doing the right things. So the idea of we're rowing really fast, we're making good time, but we don't know where we're going is the kind of conundrum that we have in dentistry, that we're really good at setting. I'm going to tell a story later on about a practice that set up a system that was very, very good at protecting the practice from not getting paid, making sure that they always got paid. But it made it difficult for patients to say yes and move through the system. Excellently managed system. Wrong system, though. Wrong system. You want a system that assists the patient in moving forward, not creates barriers that they've got to jump through and stuff like that. Fair enough.
Yeah.
So the first thing that I would say is we don't have to reinvent the wheel. Medicine has figured this out. Medicine has spent, let me back up. My wife worked for a large architectural and engineering firm here in the Detroit area called Kahn and Associates. And she did design work for space planning and design work for hospitals, schools, automobile plants, everything like that. And all of those kinds of industries have figured out how to move. Maybe it's a car being manufactured or a patient moving through a system or a student moving through a school. They have researched and figured out how those people in those kinds of business segments or industries make decisions, and move through the system. And so that work's been done. And if we just look over to medicine and we read their journals and we start to look at the playbook that medicine has for how patients make decisions about healthcare and their insurance and their physicians and what procedures they're going to choose and what risks and how they're going to weight that, we can just take that same matrix and apply it to what we're trying to do in dental sleep medicine and think more like a physician and less like a dentist. And we can usually be very, very successful. And the key to that is helping a patient. And Michael, you and I talked about this graph. We talked about this learning ladder, which is kind of fun. It's patients come in and the typical patient is unaware that they have obstructive sleep apnea. There's 40 to 55 million people in the United States today that have obstructive sleep apnea. Maybe 85% of them have not been diagnosed. Could be as high as 90. We don't know. So there's a shit ton of people. That's a scientific term. There's a shit ton of people who have, sorry, I hate to use big words like that, but there's a lot of people who have not been diagnosed. And so if a practice has 2,000 patients and 25% of them, 500, and maybe 100 of them have been diagnosed, that's still 400 patients in that practice have not been diagnosed. And so if we can, well, like your coaching, if we can figure out how to teach the verbal skills to people, to screen those folks, to have the conversations with those folks, to make them, look at the first step, aware of this thing called sleep apnea. It's not just snoring. It may just be snoring, but 90% of the time it's not. So it's probably more than snoring. You're male, you're over 50, you're overweight, you snore. That's 4 risk factors. We know on the stop banging, that means they're 92% likely to have obstructive sleep apnea. Boom. But it's not important that I know that. It's important that the patient become aware. And then because I can personalize that conversation for the patient or not, but if I can personalize that conversation for the patient, they might not just be aware, they might be that kind of sounds like me. Now they're becoming interested, they're becoming curious, and that's what we want. And if I'm talking about studies and science, and I'm showing them information, I'm probably going to be believable. And if they believe me, I might earn their trust. And if a patient looks at me and says, wow, I snore, my spouse snores, and they fit some of that profile, do you think they might have sleep apnea? I go, yeah, it sounds like they've got 4 or 5 of those risk factors. There's a very high probability that they do. Then the patient might say to me, what do you think we ought to do about that? Wow. That's the commitment statement. That's when a patient has walked up the learning ladder and they say to you, doctor, I trust you. You're in a healthcare advisory position to me. What would you recommend? And they don't always say it in those ways. I'm not suggesting that. But right. Sometimes it's that look, that facial expression, like, what would you do? And you can say to them, well, I think we should go ahead and get a test. The only way we can tell for sure, because I told you we're about 90 to 92% certain that a person in your profile would have sleep apnea, but we don't know for sure if we take a test. So let's get a test ordered up.
Yeah.
Now the action state. See, if we come way back down to unaware and we say, look, I think you might be at risk for obstructive sleep apnea. Let's order up a test. Now I've jumped to the top of the learning ladder and asked that patient to take an action that they have not committed to, might not believe or trust in me, maybe aren't as interested in. Maybe I force some awareness on them by sticking a brochure, a pamphlet, or telling them something or showing them a poster. That's a tough sell, just like it's a tough sell with periodontitis. It's a tough sell with occlusal rehabilitation. It's a tough sell with an aesthetic case. Tracking a patient and their movement up this learning ladder is a powerful way to figure out, are they ready to hear what the next step is? Because sometimes we pop that statement, we pop that question. We tell them what they need to do. Listen to the words, need to do, before they want to know.
Yeah.
Yeah. And Michael, you say it all the time. Our goal is not, as he says, our goal is not telling people what they need. It's to get them to want what we know they need. And that's the key. The same issue pops up in obstructive sleep apnea treatment, dental sleep medicine. I want that patient to say, well, I want to find out if it's just snoring or if it's sleep apnea. I want to find out if it's a serious disease. Sounds like it is. I want to find out if I have that disease. I want to find out, is it treatable? Can you help me? What do we need to do next? Boy, that's beautiful.
Yeah. And so, Mark, burning question here, and this is not in the Q&A, disclaimer, this is from me. because I hear this
Oh,
all
shit.
the time. Yeah, no, I get to ask one too. I should raise my hand with the little moniker thing.
All right.
And it seems like every office that we coach at some point in the process of that conversation. Now, to give you this scenario, mostly GPs, some specialists, but mostly GPs, they're going to be doing work on screening and identifying their own patient base.
Yep.
And they get the classic question, hey, in this conversation, hygiene and the doctor back and forth, why are you talking to me about this and my physician never has? That's an objection. Where are they at on this trust ladder? And how would you get them past that from a conversational standpoint?
Yeah. Great, Michael, that is a great question. And I love it when somebody like yourself who really understands this process and you understand, the patient's perspective, you can ask questions that sometimes don't always come up. And so that's good. Those are powerful questions. So the question there is the patient doesn't believe or trust in you yet. And the reason is because this seems really out of context. You're their dentist. And you're talking about something that my physician should have had a conversation with about. So if I start the sentence with, I have observed this, and I think you need to do this because you might have this, the patient's going to say, that doesn't seem to make any sense to me. You're not my physician. Why are you having that conversation? But if I were to start that conversation by saying, one of the questions we asked you today on your health history was this Epworth sleepiness scale. And it's got some information there that says you might have some excessive daytime sleepiness. And I can't help but know that, because it's in your health history, that you're male, you're over 50. I can see that you're carrying a couple of extra pounds. I can see that you have hypertension. I got to ask you, do you snore? And you go, yeah. And you've got some daytime sleepiness. That's 6 of these risk factors. Medicine and dentistry did not, and before I pop this next level of statement to them to help them grow on this learning ladder, medicine and dentistry didn't know very much about a thing called obstructive sleep apnea. Have you ever heard of that? Most patients will have. And most patients don't want to wear that CPAP or anything like that. But today, we're learning a lot more about it, and we're understanding how it affects so many other disease states. And so medicine and dentistry have gotten together, and we're starting to screen those patients. In fact, the American Dental Association, back in 2017, asked us to start adding these kinds of questions to our health screening questionnaires so that we did a better job of screening patients for obstructive sleep apnea to help medicine prevent some of this disease from occurring. Now I've answered that question before you can ask it. So if you inform before you perform something, then you sound really smart. Whether that's this tooth has a deep cavity, and oftentimes these deep cavities end up being very close to the nerve. And even if you don't expose the nerve today, sometimes the nerve becomes so traumatized by that the nerve dies and you might end up needing a root canal. So that 3 days later, when they've got the throbbing toothache, they're not blaming it on you because you didn't tell them anything. And now you're saying, oh, well, sometimes when we get deep, now that's an excuse. After the fact, it's an excuse. Before the fact, it's an excellent explanation. So setting the stage in those conversations, again, and this is jumping ahead to one of the slides we'll have in a minute, being intentional about those conversations, not just casual. I want us to be intentional about those conversations and explain to patients why we ask those Epworth questions, why we're talking to them about sleep apnea. And then the good news is, if I talk to 20% of the patients in your practice about the possibility of them having sleep apnea, and if I did it the right way, I'd probably find that 75 or 80% of the 20% knew something about sleep apnea, or something about snoring, or knew somebody who had sleep apnea, or somebody who wears a CPAP, or something that fits that we can connect and stay in that conversation with. Rarely is it out of the blue. Rarely. So it's really good to try to pre-connect those dots in conversation so that the patient says, wow, am I glad you're doing that screening? Am I glad you're working with medicine?
Right.
Am I glad the American Dental Association passed that resolution in 2017? And maybe you don't say 2017, you said recently passed a resolution, because I might say, well, shit, that was 4 years ago. How come you didn't ask these questions 3 years ago? I'm suing your butt, So maybe you just say the American Dental Association has even asked us to screen for all kinds of different sleep-related breathing disorders, which is true. And maybe you don't quote the year. So I like that question. That really frames it. And it makes me think too how important this walking this patient up this learning ladder is is critical before we earn the right to talk about the solutions. This could be crown and bridge, it could be occlusal therapy, perio, doesn't matter, or dental sleep medicine. Before we get the right to talk about the solutions, we have to make sure that the patients come along with us. Michael, you and I talked a little bit about a conversation that a priest had. I'm Catholic, and I'm not witnessing to anybody tonight. I'm just saying that I'm Catholic, and so I go to church on Sunday. And a number of years ago, our priest told a story that he had read about the faith journey that people go through. And I told you about this, that I always feel I'm going to get a bolt of lightning or something when I tell the story. But patients have to go on a journey with you from their head to their heart. And that's a big deal. That's 18 inches, but it's the longest 18 inches in a relationship that you can imagine. Because a patient hears knowledge, they hear information about sleep apnea, 23 times more likely to have a heart attack, 4 times more likely to have a stroke, 5 times more likely to die of COVID, all these comorbidities. They hear the percentages, the relationships. They hear that they have 4, 5, or 6 risk factors. They hear they're 90% likely to have sleep apnea. Facts, figures, science, brain. But until they get down here into the heart and trust you, until they make the journey from the head to the heart. And again, in church, we were hearing about this faith journey from the head to the heart. And it's similar, both the lightnings coming, I'm sure, but until you can make that journey, there's no sense talking about the solution. And that's what this learning ladder is. I'm creating a path. I'm creating an easy way intentionally for the patient to have a journey with me from the head to the heart. When they get there, the journey is not over. Because even though they might feel and own and understand, because of your good patient education, what's going on for them, they still have to make one more 18-inch journey from the heart to their wallets. Because if I'm practicing dental sleep medicine and I'm fee for service, I'm going to have to ask that patient to reach into their pocket and write a check. Then I'll bill their insurance and they'll get something back for it. Oh, high five, that's great. But that's a real commitment. There's a big difference between thinking, feeling, and then going, oh yeah, I get that, and spending your hard-earned money. And in the faith journey, my pastor was talking about making the journey from head to heart, and then, oh, by the way, you're giving money to the church. You can see where he was going, right? But then he said, but the journey doesn't end there. And I went, what? Yeah, because once you get to the heart, and then you move to the wallet to spend some money, you still got to go to the knees. Got to make one more 18-inch journey to the knees. To the knees, yeah. Because you want that patient to be able to pay that bill, like Dr. Penke used to say, with gratitude and appreciation. And to be able to do that, they kind of got to be on a bent knee saying, thank you so much for helping me. And all of you who do dental sleep medicine, if you've done some of this, you know, man, the accolades you get, the positive reinforcement, the feedback you get is fantastic. The texts you get. We're sleeping together again. My dog stayed in bed with me. I feel better. I have more energy. I don't get up to pee 3 times a night. All the stuff that we get to impact people's lives with. This feels great. And they're thankful.
Yeah.
But the journey still doesn't end there. There's one more trip, one more 18-inch trip to the feet, where that patient is responsible for going out and finding another patient like them for you to treat. That missionary, that referral. Mm-hmm. So do you see how this learning ladder and beyond, referral basis, appreciation and gratitude is a kind of a journey that a patient can make from head to heart, heart to wallet, wallet to knee, knee to feet. Mm-hmm. And if we think of it that way, at any time, I just think about, I look across the chair and I say, where do I think that patient is? Are they ready to hear the next piece of the story? And that keeps me focused on where that patient is, where I am, where I want them to go, and then helps me design a plan for how we're going to get there.
I love it, man. I really do. I think we could have spent an hour on just this slide. So I'm only gonna tag a couple of points that you just mentioned just to make sure everybody heard this well. This learning ladder that you're talking about, it also, each step requires an incremental level of additional trust by the patient. The more they step into this all the way up to taking action, you're garnering that trust. So like you said, by informing them ahead of time, you're not answering an objection, you're giving them information so that they can digest it and come back to you for more. I guess one other thing that you didn't mention that also kind of speaks to me is this connotation of the patient's pain points. So what they feel, that component in their heart, we find the greatest level of motivation that people have to move forward with treatment is not the outcome of living longer or feeling better in the morning. Some people do, but most are, they're worried about falling asleep behind the wheel and hurting somebody else, or they really want more out of their life. And just, I don't know, I that seemed to really, in your story, that was the number one thing that I heard. It just resonates.
I loved your idea of thinking about the pain points, because if we use the two ears we have to listen twice as much as we speak, we'll hear the patient give us clues as to where those pain points are, so that we can not from a manipulative way, but that we can guide that patient towards making a better healthcare decision based on what we hear from them about what are their concerns. Just like you said, if somebody says, "Oh my God, sometimes I pull up to the light and I feel like I could doze off at the light," then they're opening up a door to have a conversation about how you can help them not feel guilty about that by sleeping better. So that's great. That is really good.
So going back to system, because I know we got to keep going. You did dental sleep medicine back when it was the Wild West, and there's still a little bit of that, but there's so much more structure these days. Talk to us about team, like getting team involved. How did you do it? What are the things that you would have done different? How does that all work for you?
So it's critical that you find a support system for helping educate your team at the level that you want to be educated. And if you're capable of doing that, that's fantastic. But most of us are not capable of doing that. Most of us are trying to figure that out ourselves. So if you're sitting there listening to me tonight and you're thinking to myself, my son says, "Dad, you sprinkle this magic dust," and everybody leaves thinking they can do exactly what you do, and they can't. That's what he says. So if you're listening to me, you think, "Oh yeah, that's great. And you go home and you go, "It's not working for me." It's because you haven't had the right training. And so finding the right kind of programs like this, coaching, support, a network of friends, spending time with people that have been successful. I know Ryan O'Neill, for example, one of your coaches, quite well down in Nashville. And Ryan's an incredible guy. And his demeanor is so nice. And so those kinds of people to be around. I've said to people, email me, text me, and quite honestly, for your folks, I'm happy to do that, Michael. So if somebody has questions or, well, how do you talk about this? We'll get on a call, we'll do that. But you need that kind of one-on-one relationship with somebody who's been there, done that, made all the mistakes so that you don't have to make them. That's the beauty of it. My son he's an incredibly smart guy, and I learned so much from him. But he said, if he had his life to live over and he had to change one thing, he would learn to take advice earlier. And my advice would be, find somebody that can teach you and train you. My daughter she does everything about my sleep practice. I literally come in and just play dentist Mark when I'm in the practice. She does everything about it. And so she is phenomenal, but she acquired that knowledge through a great deal of coaching and training with people like you have, so that she was able to operate at a high enough level to be able to execute like that. And lots of other people have made her all kinds of great offers, but she loves the flexibility and the time that she has working with me on a part-time basis. And she's got a couple of kids. She's got a 10 and a 7-year-old, my grandsons and daughters. So she's living a dream, but it's like, you've got to have a lot of training to get to this level. And you can learn it on your own, you can, but it might take you 2 or 3 or 4 times as long as if you go and spend some time with somebody like the coaching you've got available. That's critical to get the team on board. For sure. I think now it's time for a little commercial. You let me talk about me, so let me have you talk a little bit about your successful program.
Yeah, thank you, man. Yeah, guys, just a quick 30 seconds here. If you want to learn what he's talking about, we have courses monthly. we'll have an offer for you at the end of the course or the webinar here today. Basically, we took the 2-day live course that we used to do Fridays and Saturdays, and we put it on Zoom, just like the format that you're seeing today, except we get to see each other and talk back and forth. So instead of just listening to us, you can interact. As Mark mentioned, Dr. Ryan O'Neill down here, Mr. Handsome Face, making the rest of us look good. I think really, if there's a hallmark, there's a lot of great courses out there with great presenters, people that know lots of amazing stuff. I will be the first to tell you, I'm one of the presenters on here, and there's no magic definition of sleep apnea. There's no one way to do stuff. I think if there's a hallmark for our course, it's how do you talk to people? How do you do this dialogue? Sprinkle that dust in your practice. How do you garner the soft skills with you and your team to actually get out there and do this, have the confidence to do it, and then building your system? You know, Dr. O'Neill's an amazing dentist. He's got a system built in his practice that does DSM only, garners physician referrals. He practices out of Nashville. Your system that is farming up your own patients out of your practice in network insurance or fee for service, it's going to be a different system. So our goal in this course is not to be the end all be all. It's to help you talk better and walk out Saturday afternoon with an implementation plan for your office. So yeah, thank you for allowing me the shameless plug, Mark. That's yeah, thanks.
Well, you gave me one, so I can give you one. I wanted to talk a little bit about, I've used this term intentional conversations and guiding the patient, and what does that kind of mean? So I want to give you some tools you can take back. So you can have posters, you can have brochures, you can have things on your Facebook page, testimony, you can have great stuff out there, and that's all good, and you should have all that kinds of stuff. But if a patient sees that, and then when they're sitting in your chair in their hygiene visit or in a restorative visit, and they ask you about it, I would argue that was a passive way of broaching the conversation. You put some stuff up, you hope that they would see it, and when they did, they asked you about it. So it was passive. You did want them to go somewhere, so I suppose there was some intentionality to it, but it's different than guiding a conversation. And then you flip over to the side that says intentional conversations. There's a picture of somebody taking shade, and you must be thinking that I've lost my mind and I'm back into teaching restorative dentistry down at the Pankey Institute or at the AACD meeting or something like that, and I'm not. What it is I was teaching a shade course for Vita Porcelain, the Vita Porcelain company years ago, and we were using these digital shade taking machines called Easy Shade. And I can't even tell you what state I was in. I don't recall. I want to say it was New York or New Jersey. It doesn't matter. Somewhere out east. And there's about 16 or 18 dentists in the room. We were talking about shade taking. One of the docs had the machine. And so he got up and sort of said, oh, I love this thing. I do this, I do that. And here's what the dentist said. The dentist said, and so when I'm taking shade on all my new patients, I do this and I do that. And I go, whoa, 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 what'd you say? And he said, well, when I'm taking shade on all my new patients. I'm talking about curiosity. I had curiosity. I was walking up this learning ladder. I wanted to know more. I became aware of something and I was interested and I wanted to know more. And I said, well, why do you take shade on all your new patients? And thinking back now, I could see that he was just like, he caught this big fish and he was going to reel me in to the conversation because it was intentional. And he said, well, Mark, simply, he says, I used to ask these questions like, if you could snap your fingers, if you could wave a magic wand and you could change one thing about your smile, what would it be? I was trying to stimulate a conversation about aesthetics with patients. And I felt like I was being a little manipulative. I said, yeah, okay, I get that. He said, so we started using this machine, but you could just do it manually. It doesn't matter. And I started taking shade on every patient. So during the new patient exam, perio, gum, oral cancer exam, TMD, muscle palpation, great. Now I'd like to take a baseline shade. And they'd pick up the shade guide or pick up the Easy Shade. And they'd say, yeah, it's an A3, it's an A3.5, or it's an A2-1, whatever it is. And just say it, write it down. Say it, write it down. Say it, write it down. Nothing else. He said, Mark, after you say the shades of some of their anterior teeth, there's only two types of patients left in the world. Ones that ask you what shade they were, and some that don't. And the ones that ask you will say something like, so what shade was I? And so you get out the shade guide and you show them on the shade guide what shade they were, and they go, ooh, and they're arranged from value, from highest value to lowest value. And they're like, ooh, oh, that A3, that's kind of gross. You go, no, that's actually a very common, that's a very average shade. Nobody wants to be average. So that's a very average shade. You're very average. And so they're like, well, what about these over there? What the patient was doing was because they become curious about what you were doing. And they asked you, tell me, what was I? What score did I get? And you told them the score. And then you showed them the scorecard. And they saw where they were on the scorecard. And they said, I don't like that. I want to be over here. They opened the door to have an aesthetic conversation with them about bleaching, veneers, dentistry, etc. And I thought, that's brilliant. And I thought, that's really what we want to do with the Epworth Sleepiness Scale. With the ESS, which is meaningless from a correlative standpoint, lots of people are tired during the day for a variety of reasons, doesn't correlate well with sleep apnea, but it opens the door to have a conversation with patients about your daytime sleepiness is one factor. I know your sex, you're male. I know your age, you're over 50. I can ask about snoring. I can see your comorbidities and your health history. If you're overweight, I can assess your neck visually, or I can measure it if I wanted to, but I know you've probably got a 17 neck. So I'm pretty sure here you've got the scorecard that says you are very likely, because you have 4 or more risk factors. Yeah, there's a 90 to 92%, depending on which algorithm you use, probability that patient has obstructive sleep apnea. So now you've identified a patient in your population where you can have an intentional conversation with them about creating an awareness. Remember these words? Moving from head to heart, getting them interested. Because you're quoting statistics and data, they're likely to believe you and trust in you. And you wait for them to say, well, what do you think? I think the best thing we can do is, I'd love to order you up a sleep test and find out for sure. And the beauty of that is if a patient were to say to you, well, what does that cost? Because you are their dentist, for God's sakes. And if they say, what would that cost? You'd say, well, it's covered by your medical insurance. Now, we're happy to charge you something for it, but we'll bill to your medical insurance and you'll get a reimbursement for that. It's covered by your medical insurance. Nobody goes into the physician. When the physician says, we need to draw some blood today and take a chest x-ray, nobody says, so what does that cost? Nobody says that. They just get it done. So this whole conversation about medical necessity versus discretionary expenses is an important consideration, the difference between medicine and dentistry. So we can use the kinds of conversations we're having. We can use the patient education conversations we have to help answer the 3 questions that every single medical patient has. And that is, do I have this disease, this sleep apnea thing you're talking about? I don't know. Let's go ahead and order you up a test. Is it serious? I told you it's 23 times more likely to die of a heart attack, 4 times more likely to have a stroke, 5 times more likely to die of COVID. Look at these comorbidities. You're tired, you snore, you sleep in separate bedrooms. Can you treat it? Yeah, we can. We've got to find some ways to talk about CPAP, oral appliance therapy, surgery, positional, weight loss, all the different components. But I've got to answer these 3 questions. And it's far better to not just tell somebody they have this disease or tell somebody they're likely to have this disease. It's to have them walk up the learning ladder and say, well, I want to know if I have this, because I can tell from what you said it's serious. And it looks like you've got some treatment options for me that might work out, but we got to find out if we have this. You go, exactly. Let's get you tested. Now, boom, throw them off to awake and sleep, get them tested. They come back. Sure enough, they've got it. Positive test, ready to treat. Get them into an oral appliance if it's mild or moderate. Talk about CPAP if it's severe, whatever your protocol, your process is, whatever your process map looks like. Good to go. But you've got to answer these 3 questions in advance. So let's spend a couple of seconds on each one of these. I want to just make sure that we highlight, how do we answer these questions? Do I have this? Well, this is a form I use. You can make up your own like this. It's got some information about sleep apnea and risks and everything like that. And then it's got these questions. And I've got this, I call my simple stop bang. And do you snore? Observe stop breathing, over 50, male, overweight, large neck, high blood pressure, arrhythmias. I would include GERD and other things like that. Are you tired often? And then down below that, 3 correct answers, check marks. 3 indicates a moderate risk. That's true. Chest magazine, the pulmonary specialist magazine, talks about the algorithm and the math behind these questions, and it's very, very sound. 4 or more is a high risk. What's a high risk? 92%, according to Chest. 3 indicates an 81%. 81%, if 3 of these are right. That's every male over 50 who snores, or every male over 50 who's overweight. And if they have an oversized neck, they get 4, boom, 92%. That's crazy. Every one of those people should have a sleep test. So when we look at our patient population and we're talking to our team, these give them some guidelines that help them make better decisions. And the snoring question is important because you can download an app like Snore Lab, one word, SNORELAB. And this is before treatment. You can see the date, April 18th. The next day we gave them an oral appliance. Actually, this is, I think, a week later. But the next day it showed up for 4 minutes, doesn't matter. A week later, we gave them another one, dropped down to 1 minute. A week later, we advanced them and they dropped down to 0. But you can see the dramatic improvement if I hold your lower jaw forward. So do I have this? I don't know. Do I snore? Well, if you've got a spouse and they kicked you out of the room, probably. If you don't know, download the Snore Lab app. And the Snore Lab app will let you record every other night, up to 3 nights. When you record the 4th night, it drops the 1st. Won't let you listen to the whole night snoring, which would be boring anyhow, but it'll let you listen to little snippets of it. The score doesn't matter, but look at the percentage. It's epic. 1 hour and 25 of epic snoring. That's a big deal. Put an oral appliance in, advance your mandible, it drops down in 1 minute. So those are powerful things. Do I have this? I don't know. Let's go find out. We need a test. Is it serious? Oh, hell yes, it's serious. Michael and his team will make available these 8 slides that we use. You can make up your own. You can use mine and doctor them up to meet your own needs. It doesn't matter. But I talk about, is it serious? Well, yeah, I talk about how we're the only mammals. We're the only mammals that have sleep apnea because our uvula that hangs down and our epiglottis that protects our airway, we're the only mammals where that doesn't overlap. And so there's this great wet mucousy area for the tongue to fall back and close off the airway. In infants, they do overlap, but during the first year, they start to separate as we develop our neck and our vocal systems. And then we talk about the Wisconsin cohort study. And then we talk about 23 times more likely to have a heart attack, 4 times more likely to have a stroke. You've heard me say that. Then all these different comorbidities. Then we talk about the different treatment options and with the pros and the cons. We talk about non-compliance with CPAP being the Achilles heel to a treatment that really works well, but nobody wants to take it. If I gave you a pill that solved your high blood pressure, but it meant you couldn't walk and you have to roll around in a wheelchair, nobody would take that medicine. Nobody would take that. So the cure can't be worse than the disease. And then we talk about, well, what do we do next? Well, we either get a polysomnogram or a home sleep test. Nobody wants the polysomnogram. Good news today, instead of it being like 60-40, now it's about 90% home sleep tests. Mm-hmm. Isn't that about what you're finding, Michael? 90-95% home sleep tests?
Yep.
Yeah.
Yep.
So it's
so
much easier.
Choice.
Yeah. So much easier to get the home sleep test. So we've got this series of slides that helps us answer the question, is it serious? Oh, hell yes, it's serious. I want that patient, I don't want to say scared out of their minds to find out whether or not they have sleep apnea, but I want them curious as hell. And then is it treatable? Yeah. I want to have some testimonials. I want to have testimonials on Facebook that they maybe have seen so they believe that there's some hope. Mm-hmm. I want them to have testimonials I can show them while they're sitting there in the chair. But one of the things I do, I call it a poor man's pharyngometer, is I do a snore test. And I say to a patient, well, do me a favor. I said, lean your head back, pinch your nose, and make a snoring sound. And there's a lot of people online right now. So I hope in unison, we should turn on all the microphones, have everything back. Make a good snoring sound. Then stick your jaw forward and try to make a snoring sound. And it's a lot harder. And when a patient does it, they go, oh my God, that's amazing. Now, they don't all do that because once in a while, they can still make that sound. And when they can still make that sound, they go, oh crap, I'm screwed. I'm going to have trouble treating that patient. And you might. But the idea is instead of a acoustic pharyngometry, or instead of a matrix where I test out the different positions, or instead of a CBCT scan where I can show a 3-dimensional change in the airway, I'm saying, when you make a snoring sound and you stick your jaw forward, you can't, I'm opening your airway. Does that seem to help? And if it seems to help, the patient goes, wow, yeah, I think this might work for me. So you want to say, do you have this disease? Well, we got to get a test. Is it serious? Oh, hell yes. Is it treatable? Yeah. If this doesn't work, I can always pump air down your tube. That's a CPAP mask. But I've got to give you hope that we can take you someplace where you're going to get resolved and feel better and sleep better and all that kind of stuff. So it's those 3 questions, and the answer to those 3 questions is critical.
Yeah. Yeah. And I think I love the way the questions are positioned, Mark, is that you're pulling them, you're guiding them up that ladder, right? Totally. It's not a 100%. Shoving them. You're coming in with a bunch of stats. I mean, you've said 23 times, 4 times, 5 times, at least a few times tonight. that repetition starts to build some confidence, but you can be passionate about it because you're pulling them up the ladder. You're pulling them with the clinical data, with the connection to their pain points, not shoving them in a direction that they may or may not want to go. I think that's a big difference conversationally that you're talking about here.
I love that the way you're saying it is so I'm guiding somebody to where I think would be a better place for them. I would never do that and sell them something they didn't need, or sell them something they didn't want. My goal would be to get them to want what I think they might need. And I think I have some answers for most of those patients. We have really high success. I use a lot of PreSonus devices, so they're smaller. We don't have to advance the mandibles as much. We have a lot of fun. But when we do that, I get about 94% success rate with mild cases, 85% with moderate. I drop way down to 50-50 with severe. So when somebody comes in and they're severe, I'm more inclined to talk about CPAP. I don't want to talk about CPAP. I'd rather make them an oral appliance financially. For me, that's my interest in it. But because I've got to do the right thing with the patient. But here's the beauty of this. If I convinced 100% of my patients to try CPAP, I know that 60% will fail in the first year. I get 60% of them back. And now I can try the 50-50 chance with the oral appliance for them. And they're going to be very motivated to try that because they already failed this other therapy because it was a pain in the ass. And so that's great. That's really great.
Yeah. I love the idea. So this is way past the home sleep test conversation, but just sprinkling some of that dust.
Yeah.
When you're in a treatment planning conversation on the clinical side, and you talk about is it serious? Absolutely. Look at all the different surgeries that are available to you. Here's CPAP, here's BiPAP. And then you talk about an oral appliance and you're like, wait, this is the least invasive option you have at your disposal based on the physician's recommendation.
I always talk about
surgical CPAP.
Yeah, I always talk about surgical options like Inspire, because most people don't realize it's a surgical option. So I always say, that commercial is great. I go, those commercials are awesome. Every patient's seen those, and I say, no mask, no hose, just sleep. I go, they should say no mask, no hose, a little bit of surgery, and sleep, because they implant a pacemaker-like thing in your chest that leaves you a lump right there, and then they run some wires up through your neck to the base of your tongue, and people are like, what? Yeah, I don't paint a very pretty picture. And it's for a very narrow spectrum of sleep apnea patients. So, I mean, it's a great therapy, but it's 50 grand and it's pretty invasive. So, yeah. So anyhow, I'm looking at 7 minutes left. So here's the slide that puts it all together. So we really have to be patient focused. I think that's become clear tonight. But me first, I have to have a little bit of a paradigm shift. I have to realize that I'm in medicine. And then my team has to get there with me, but I have to lead them there. And then I have to have the right kinds of treatment options. And then we have to be able to talk about payment. So when we're talking about putting together this process map, medicine puts together process maps just like manufacturing, just like service industries. The process map would be, oversimplified, it would be screen, test, treat, and bill. And then all the little pieces of the puzzle and all these places where you could have moments of impact that help those patients make better decisions all along that process map. And this is why when you and I talked in the beginning about this, the systems and system implementation, how it's important to say, okay, I'm going to screen my own existing patients, high five. I'm going to send them to Awaken to Sleep for a sleep test. And maybe I'm going to send 75 or 80% of my patients there. I'm going to send a few patients to my local physicians who have really wackadoodle health histories or something like that. Okay, fine. And then you say, and then when they come back, I'm going to treat most of those patients with oral appliances if they get a letter of medical necessity and a prescription. Some of them are going to need to go for CPAP because they're severe for a variety of reasons. And that's part of the game. That's the way it's going to work. So, if you saw 10 patients that needed a sleep test, 9 of them are going to come back positive. Of the 9 that come back positive, 3 are severe, 3 are mild, 3 are moderate. So you're going to treat 6, maybe 7 of those. That's a pretty good ratio. So you're going to look at that process map. You're going to keep track of things. And then you got to be comfortable saying, am I going to participate with insurance? That has its advantages. Physicians will like that. Patients will like that. But your pocketbook might not like that. And so the idea of being fee for service has dramatic advantages. And it isn't like you're taking away the patient's benefits. You're still going to fill out forms for them and send them off for them. And the patient's benefits just going to come to them. You just really don't care if they pay $1,500 or $2,500 or $3,500. You're going to charge them whatever you're going to charge them. So it's we've been selling dentistry far more expensive than that forever. And so if we can't sell a medically necessary treatment, shame on us. But we should expect some sort of high degree of success. I said that I would tell a story. I worked with a practice out in the Pacific Northwest that was getting 60 referrals a month of patients coming in with a prescription and a sleep test from a physician. And they were closing 14 a month, 22%, because they had them fill out extensive financial paperwork. They had them go through a big explanation about benefits, what would and wouldn't be covered, what it could cost them out of pocket. And then they had to sign a financial agreement, and they had to make a significant down payment. And they were closing 14 of those patients. And as they went along, we took away some of those barriers, some of those financial documents, and started to put some trust in those patients to pay their bills. And I'm sure not all of them did, but they went from, I'm not kidding you, from 22% to 90%, 80% in 1 month, 90% over about 3 months. That's 54, that's 40 more patients. Even if 10% of them, 4 didn't pay. Can you imagine the math on that? Having 40 more patients, 36, even if 10% of them didn't pay, and it's never been that bad for them. So don't think about setting up a system that protects you so much from not getting paid. Try to find a way to help your patients go through the system as they get educated and make better decisions in their healthcare future. And I think you'll be super successful. And that's one of the beauties of working with the folks from Awaken to Sleep, is they've got coaching in place to be able to help you with whatever your systems are going to be. They'll tailor that to you. And then all the folks that will come in, whether it's Manning, whether it's O'Neill, they'll come in and help guide you towards whatever it is you're designing as your process map and your protocol series. I think that's fair enough.
Yeah. Mark, thanks for that. And I think you bring up an awesome point there with that practice. Guys, if you're tuned in and you're thinking, well, shoot, how do I deal with that on the fee-for-service side? Because we kind of paired this back and forth all night. On the fee-for-service side, what he said translates to you're asking for all of it or half of it up front versus you're willing to go with third-party financing or for some
Care Credit, for Pete's sakes. Care Credit is your buddy right here, right?
Yeah.
What do you care if you give up 10 points or 8 points or something the patient pays for over 12 months? What do you care?
Right.
Oh my God. That would be, that's cheap money. Charge $3,500 and pay $350 to get your cash up front all day.
Yeah.
All day, or whatever your math is.
Yeah. Well, hey, so I see the slide up here. So I'll tell you guys, if you want to come to one of our courses, like we mentioned earlier, it's a Friday, Saturday, 14 CEs, and it's you plus 4 of your team members. So 5 people total, 14 CEs. I can't do the math on that, but it's $400. So you get a $200 discount. It is some of the cheapest CE around. Now, I have to tell you, if you log on and don't show up with your face and your microphone, we will literally mock you on this dialogue back. I'm just kidding. No, the goal here, folks, is we want to give our best foot forward. We can do that in a weekend. Yep, you get CEs. More important than that, get your team energized. If you're looking at doing this and having some fun, we're going to have some fun over the weekend. And, you know, we're happy to give you a discount and make grease the wheels a little bit. Discount.
I'll help your folks. I'll help your folks pay for that course. If they have not had a chance to try Evo and they want to, email me and I'll hook you up with somebody from Pasomnis, and I'll make sure that they save you enough money off of the first 3 or 4 or 5 Pasomnis devices you do that you can more than pay for that course. How's that?
That's awesome, man. I appreciate that. Yeah. So if you go to that website, use PS200. That's going to be good until next Friday. So you've got a few days, think about it. If you want to book a course, we've got the entire the rest of the calendar year up for you to pick a weekend that works for you. Guys, we're not shysters. If you book a course and you can't make it, let us know before the course starts, so we're not holding your seat, and we'll move you to another course. So if you're interested and you think a weekend works, book it. If you have to move it, we can move it, no problem. We got Q&A and we're at the end of our hour. So I want to get a couple of questions in.
Make them easy. Make them easy.
No, actually, we've got Dr. Kumar tuned in from Bangalore. And he said, Dr. Murphy, every time I hear you, I learn something new. Thank you.
Well, thank you so much for that. I have not been to Bangalore, but I did speak at the Southeastern Asian Sleep Medicine Conference in Jalandhar 3 years ago up in Punjab, in the state of Punjab. So I hope to get to Bangalore and that part of your country. We loved the country. The food was incredible. The people were incredible. It was an amazing trip, that's for sure. Learned a lot.
Cool. And Tony, from the other side of the world, he said, if doctors aren't screening for sleep apnea in the hillbilly world where he's from, we just call them stupid. Thanks, Tony, for that. We appreciate your humor.
That's a technical term.
Yeah. So another question for you, Mark, since you're here, sprinkling the magic dust. If you could give any insight on the dialogue, the back and forth dialogue between hygienist, who usually opens up this kind of a conversation in a GP office, and the doctor, how would you do that? Or just give us any insight you can on that dynamic about unfolding this stuff in their head, going to their heart, pulling them up that ladder. How would you do it?
Yeah. So a strong hygienist would have seen the upward sleepiness questions or something like that on the health history and had a reason to have a little bit of a conversation with the patient. So when the doctor walks in the room, talk about the MO on number 14 and the crown that they still have to have done on number 5 or whatever it is. But you change the thing, but also I was even more concerned. Mr. Jones here filled out the questionnaire about the sleep scale, and he actually does have some excessive daytime sleepiness. And with his overall size, BMI, age, and hypertension and stuff like that, I told him that you would have an opportunity to talk to him a little bit about his risk for sleep apnea. So I would grease the skids for the conversation that was coming and set up the patient to hear that here's this. It's not a third-party verification, but I'm setting up as the hygienist had a little bit of the conversation with the patient. You don't have to close a deal, just have the conversation. And now the doctors are going to come in and say, yeah, I see that. So that's interesting. So tell me, now there's a beautiful opportunity for the doctor to say, so I just got to ask you also, do you snore anything? Has your wife ever said that you snore? Yeah, she does. Has she ever caught you where you kind of gasp a little bit when you're breathing? No, she hasn't done that. Okay. Well, it does sound like you're at a pretty high risk for this. And then you can kind of just roll into the, one of the issues you're about. I'd love to get you over for a separate appointment where we could talk about that. I'd love to separate that out of that appointment if I can. You can't always do that. But if you could separate that out from that appointment, that's a more powerful setting because you put in a level of importance on it that I want to talk to you about it, show you some slides and have the conversation. But if not, then you say, well, listen, let's see if we could get on a call. Now we're doing so much telemedicine. You're done with your cleaning here today. I'm doing my dental exam. Let's set aside a little bit of time, or you and I jump on a call. Is there a convenient time where we can get on there? I want to kind of go over some of this with you, talk to you a little bit about sleep apnea. And usually the patient will say, well, my brother has it, or my dad, there's going to be some piece of the story. So run with that. If your schedule allows it, wouldn't be my first choice. I'd finish that consultation right there. I'd prefer to separate that appointment out if I could, though.
Got it.
What do you normally coach folks to do? Separate it out or keep it at that time if you can? Whatever works.
Yeah, I think part of it is whatever works. In some practices where they're dealing with schedule issues and they're booked solid, finding if they have a home sleep test that they hand out, we're finding a treatment consult 7 days from now. That's a challenge. So if it's in that scenario, we're going to say, man, while the iron's hot, if they're interested, I think to your point, they demonstrate interest, they want to take the next step, give them an option to do that ahead of time before that next consult. And if they don't want to, then we should have that conversation when they come back in a week.
Sure.
Yeah.
All right.
I think it works both ways. It's not a one size fits all, but I think even in practices that have a system, part of the system needs to have contingencies. You may want to try to have all those conversations first, guys. And then you're like, well, shoot, if I try to do that, it's going to make shoving the horse's face into water. Let's not do that. We got to pull them up the ladder, not push them off the cliff.
You're absolutely, it's pull, not push. You're absolutely right. Perfect.
Yeah.
Okay. Thank you, man. Appreciate it.
Yeah, this is fantastic and a little bit late your time. So we appreciate you. No, any last parting words, Mark?
No, email me at mmurphy@prosomnus.com if you want me to pay for that $397. I'm happy to do that with discounting some sleep devices for you, something like that. getting started if you haven't used PreSomnus. And then if you got any questions or you want those 8 slides I use, or you want to copy the slides we use tonight, whatever you need to support the video that you watch, happy to send all that to you. If you got questions about any explanations, I'm happy to jump on a call and help you do that. So I want you to be successful. So does Awaken to Sleep. So let's knock it out of the park. We need more doctors doing more sleep.
Yep, that's fact.
Amen.
Hey, thanks for your time. Have a great night, y'all. Thanks for joining us. And just in case you missed it, we're going to leave the meeting up for a moment so you can click that link and get your CEs or check out those events. So hope you have a great night, and we'll see you next time. Mark.
Thanks ever so much.
Again.
Appreciate it.
Yep.
Thanks, Michael. Always good talking to you.
You too, man. Have a great night.